Good morning, everyone. I'm obviously not Carol Lang. I don't have the height genes in my family, my name is Laura Morrow. I'm a faculty member at the U here, and I've been collaborating with Carol for a number of years. I'm really, really happy to have the opportunity to introduce our speaker this morning, Dr. Melissa Geller. She's a gynecologic oncologist in the Division of Gynecologic Oncology and also an associate professor here. I really have to say that Dr. Geller's approach, for me, I believe, reflects how intellectual insight as well as genuine support can really help to foster very successful collaborative clinical research and also advance patient care. I know both Carol and I have had extensive experience working with Melissa. Her willingness to share her clinical expertise and her continuous encouragement of really insane ideas has helped to spearhead our recent prospective biospecimen trial. So it's not surprising that she serves as research director in her division, as well as she's really spearheaded a lot of innovative clinical research trials and projects where she served as either PI or collaborator, gotten funding from federal agencies such as NIH and DOD, private foundations like the Minnesota Ovarian Cancer Alliance, as well as industry partners that she works with. She's also received many honors for her work in the clinic providing patient care, as well as providing advancement in patient education. So it gives me great pleasure to have Dr. Geller talk to you today about her exciting research in the area of cancer immunotherapy. She's going to talk to you about NK cells in the treatment of ovarian cancer.
Thank you very much. I appreciate it. And if you can't hear me, let me know. I'll turn that up. I appreciate the nice words. It's been a pleasure working with you. And moving forward, hopefully it will get funded again. So I have to tell you, last night I woke up with a bad dream because I dreamt that I was standing in front of you guys for 30 minutes and I couldn't get my slides to work. And Barbara Bush was introducing me, and I think it was from the flipping of the coin, and I couldn't figure it out. I woke up and I was like all uncomfortable about this, and so I got here early this morning to make sure the slides were working, and Barbara was not here. So what I want to talk to you, so again, I'm a gynecological oncologist. I'm a surgeon. A lot of the work that I've been done here is a collaborative effort on the part of the members of my lab, and I want to just go a little bit in review ovarian cancer for those of you who are not as familiar with this disease. I'm going to talk a little bit about the clinical trials we've been doing with the allogeneic IP, or intraperitoneal NK cell therapy, with an oral drug called an IDO inhibitor, as well as a new trial that we have planned. I want to show you some of the data that we have coming out of our laboratory using checkpoint blockade with a drug called pembrolizumab that looks really promising in this disease, and then a new trial that we have on the horizon using IL-15 as a maintenance therapy. So for those of you who don't know, ovarian cancer is unfortunately, we see it quite a bit here. We're a large referral center. About worldwide, if you look, there are about 200,000 women who are diagnosed with this disease worldwide, and of those, about 125,000 will die from this disease. In the U.S., it accounts for more deaths than any of the other cancers that we treat. We see a ton of endometrial cancer. We see vulvar cancer, cervical cancer, but of the cancers that we see people die most frequently from, it's from ovarian cancer. We'll see about 22,000 new cases this year, and of those, 14,000 deaths. So the ratio is not great. I know it's early in the morning, and I tend to show these pictures because this is what I do on a daily basis. But I think it's really important for people to see the amount of disease that the majority of women who present to us have in their abdominal cavity. So if you look here in this picture, this is a big omental cake. The majority of the women we see, so about 75 to 80% of women will show up in my office looking distended. They have ascites. They look 9 months pregnant, and that's because their disease is pretty insidious. It's a slow-growing disease. They may have some GI symptoms. They get passed back and forth between their primary care doctor and GI doctors, and ultimately end up in the operating room with disease that's widely metastatic. This is a really big ovary that we've taken out of patients. Time and time again, people say, okay, so how do you treat this disease? So surgically is the number one way to treat this. And so this has been shown time and time again. So if you look at this graph here, so look at this is percent cytoreduction. So we spend hours and hours in the operating room debulking patients. And so that is because you can see that the amount of disease that I remove depends on really how long these people live. And again, that's really key. So if we can get these people optimally cytoreduced, that means the disease is less than, now we say microscopic. We used to say less than 2 centimeters of disease. That as time has gone on, we've changed that. So our goal is really to get them down to microscopic disease. We can't always do that, and you leave the operating room feeling pretty badly if you can't do it, because you know that that prognosis is going to be much worse. So in order to get these patients optimally cytoreduced, we remove the uterus, we remove ovaries, we remove any pelvic tumor. We spend a lot of time debulking the upper diaphragm, the omentum. We do splenectomies just to get as much disease out of the patient as possible. So if you look at over the years and the percent surviving for 5 years, it really depends on what stage they are. So some people, albeit few, I can probably count on both hands the number of patients who have early stage disease. So if you look at these patients who have localized disease, so disease confined to the pelvis or to the ovaries, their survival is somewhere around 80 to 90% at 5 years. When you have distant disease, so upper abdominal disease, that really drops to less than 30%. So we know going to the operating room, the majority of the patients that we see are going to have a 5-year overall survival of less than 30%. If you look at all comers, again, it remains less than 50%. And if you, unfortunately, over time, this has not changed. So if you look back 1975, you can just look at this straight line, the number of deaths, and the number of new cases here. Again, that less than 50% 5-year overall survival has not really changed. And that's despite everything we've done with intraperitoneal chemotherapy, which I'll talk to you a little bit about. All these new targeted agents, we really have not made a huge dent in 5-year overall survival for these patients. And the reason for this is the majority of women will recur. So once a patient recurs with ovarian cancer, we tend to call it a more chronic disease. We cannot cure them at that point. So 75% of the patients will relapse. The majority of them are going to recur within the first 2 years of their completion of their chemotherapy. And after they recur, their median progression-free survival is about 16 months. So once they recur, we treat them again, and then it's this never-ending constant treatment. Treatment options, sometimes if we get these patients a year out from their original surgery and their original chemotherapy, we can go back to the operating room and debulk them again. It's almost like starting over. So if they have localized disease, we can go back. Most patients are going to be retreated with a taxane and a platinum. So those are most common chemotherapy that we give as second line. Other times, rarely we'll give a radiation locally, or we recommend clinical trials if they're available. So when patients recur, and this is the issue, we really group them according to how long they got out from their last chemotherapy. So when patients have a progression-free survival greater than 6 months, so if they recur greater than 6 months from the last chemotherapy, they're called platinum sensitive. Their response rates are somewhere around 27 to 65% with what we have currently available to us. And their median survival at that point is anywhere from about 12 months to 24 months after recurrence. If these people are the ones that we have a real problem with. So those people who are what we call platinum resistant or platinum refractory, meaning that they recur within the first 6 months of having completed their therapy, their response rates are really poor. So less than 20% response rates, somewhere in the range of 10 to 15%, and their median progression-free survival is somewhere around 3 to 6 months. And so these are the people that we have really major problems with finding anything, and we can't get them to respond. And so again, this is just an example of what this tumor looks like. In these type of patients, this is how they die. They die of bowel obstructions because the tumor just, implants on the bowel, and they have no bowel function. So if you look at the phase 3 current positive phase 3 trials that we have in recurrent disease, the ones in red are the ones that are platinum sensitive, like I talked about. Again, progression-free survival somewhere between 8 and 6 and 12 months. That's about as much as we can get with any one therapy that we have available to us today. And then those people who are in green, those patients who are resistant, again, their progression-free survival is really poor. And so these are the patients that we're really trying to target and define new therapies. So what next? And this is kind of what brings me to what we're trying to do clinically as well as in the laboratory. So we've spent multiple decades trying to improve survival for women with ovarian cancer. Like I mentioned before, the 5-year overall survival has really remained stable over multiple years. So we now know, and many of you in this audience know, that really trying to manipulate a cancer's immune system of a patient is now starting to be a reality for people. If you look at what's going on in melanoma and in lung cancer, these cancers are really, the paradigm's changing in what we have to offer them because of the manipulation of the immune system. So what about ovarian cancer? We're behind, as we always are. It's not a huge disease like breast. It's not a huge disease like lung cancer. So we always are delayed a little bit in our therapies. So we really think that NK cells may represent a potent immunotherapeutic approach to curing or to at least delaying the onset of recurrence in this disease. So what's the rationale for looking at ovarian cancer? I think it's a good disease in which to look at immunotherapy in for multiple reasons. So the good news about ovarian cancer, if there is good news about it, is that it really does not affect or impact the immune system. It doesn't go to the bone marrow. It rarely goes metastatic to the bone. It tends to stay within the peritoneal cavity, rarely goes to brain or other places. So when it recurs, it usually is within the abdominal cavity. The standard chemotherapy we give right now is cytotoxic chemotherapy. It depresses the immune system, but it's not wiping it out. It's not like in stem cell transplants or in other tumors where they're giving high-dose chemotherapy and the immune system is completely knocked out. We rarely do that in this disease. The other good news is the majority of the patients that we treat, so about 75 to 80% of the patients we treat will respond to frontline therapy. It's amazing. The disease will go away and they'll be without disease for some period of time. And I really think that it's during that period of time that we have the ability to manipulate the immune system and to kind of activate the immune system to fight off or try to fight off these cancer cells. So there has been evidence of immunosurveillance in ovarian cancer, and this dates back to early 2000, 2003. In New England Journal of Medicine, there was an article published about looking at CD3 T cells infiltrating into ovarian cancer tumors. Those patients who had a significant number of CD3 infiltrating T lymphocytes had a significantly greater improvement in survival, so 46% overall survival at 5 years versus less than 20% if they had fewer T cells infiltrating. So that was our kind of first clue that there was something immunological going on in ovarian cancer. What then we looked at is some data from Carlston and colleagues at the Karolinska Institute that looked at resting NK cells against ovarian cancer cell lines. And if you look at that, so the resting NK cells are the ones that are in the white, and the black ones are the IL-2 activated. And these are against multiple different ovarian cancer cell lines. So that's kind of what triggered us to say, well, maybe ovarian cancer really is a disease that we could treat with immunotherapy. So recently, we've been collaborating with some colleagues from the Netherlands. Harry Dolstra provided me with this figure, and this is some of their data that really was exciting to us and showed that, and what they did is they looked in the intraperitoneal cavity of women with high-grade serous ovarian cancer and those who had just benign disease. And if you look at this, so this was a graph of the NK cells and the NKT cells in patients who are benign that are in the white boxes and malignant in the black boxes. And if you look at that, the patients who had benign disease had significantly more NK cells than those patients who had malignant disease. And what they found, interestingly enough, and if you look at this Kaplan-Meier curve, is that women with ovarian cancer had significantly lower number of NK cells within the peritoneal cavity, and that the lower that number, the worse their survival and outcome. And this, again, is shown here, just the median number of NK cells and correlated with survival. So when we saw that, we were excited. They had a large number of patients that they looked at, and that really led us to the fact that us doing the clinical trial we were doing may be important clinically in terms of survival, if we can increase the number of NK cells within the peritoneal cavity. So I don't know how many of you know we were doing a phase 1 trial looking at the use of an oral IDO inhibitor from Insight with intraperitoneal delivery of an allogeneic NK cell product. And this was after a high-dose Cytoxan fludarabine regimen. And this really was modeled after Jeff Miller's heme protocol. And we had done this, and I'm not going to show the data, we had done this with IV allogeneic NK cell therapy. We published those findings in 14 ovarian cancer patients with the combination of breast cancer patients, and we did find some expansion after IV delivery. So we, based on some of the lab work we were doing, we decided since this is an intraperitoneal disease, we're going to deliver the NK cells within the abdomen and pelvis. So we had high hopes for this trial. We wanted to accrue 20 patients over 3 years, and lo and behold, we accrued 2. And so I'm going to tell you why in a minute. Let me just tell you real quick. So the IDO inhibitor, so the reason we were testing this drug is that we know that IDO plays a role in basically induction of tolerance to malignancy. So IDO is basically an enzyme that catabolizes the essential amino acid tryptophan to kynurin. And so what is known is that overexpression of IDO, which is seen in patients with ovarian cancer, leads to basically tryptophan depletion and kynurin excess. And when you have kynurin excess, it leads to inhibition of both T cells and NK cells that really prevent immune recognition and attack of the ovarian cancer cells. So we know that this has been, IDO can be chronically upregulated, and it's kind of a tumor-derived mechanism of immune escape. And so we had available through Insight this drug, this IDO inhibitor to test. We thought this was really exciting because based on our original trial where we used high-dose Cytoxan and fludarabine, what we found, and this is a group of patients that were all treated with high-dose Cytoxan and fludarabine IV. And the thought behind this is with high-dose chemotherapy, you're making space for the new NK cells to come in. What we found is that prior to chemotherapy, through day 7, the kynurin to tryptophan ratios were fairly low. But it was by day 14 that we saw a significant rise in these K to T ratios, the kynurin to tryptophan. And so if you look at this here in terms of what's happening, so the tryptophan, high levels of IDO go to kynurin. Kynurin inhibits both T cells and NK cells. So we were thinking that this was a result of the high-dose chemotherapy that was given, and by day 14, we were seeing inhibition of both T cells and NK cells. So because of this, we wanted to really try to inhibit this IDO, and by doing that, we did that with the Insight drug, the IDO inhibitor, and the hope is that we could reverse that ratio of tryptophan to kynurin with the oral IDO. Our hope was we would increase T cells and NK cells and make them stick around. We know, based on other data, that IDO plays a significant role in patients with ovarian cancer. It tends to be overexpressed in patients who have the taxane-resistant ovarian cancer. And so if you look at both these overall survival and progression-free survival curves, those patients who had lower IDO levels do much better in terms of survival and progression-free survival. So this was our schema that we were using. And so again, and this goes back to why patients wouldn't go on this trial. So our goal was to get patients admitted on day -6 for high dose. So they got 2 doses of high dose Cytoxan and daily fludarabine. At that point, they had a donor-related, so this is the CD3, CD19, so it's a depleted product. So it's T-cell, B-cell depleted product from a donor, so a related donor, so a sister or mother or brother who would give the NK cells at this point, and then we would infuse them intraperitoneally on day number 0. The patients started taking the oral IDO inhibitor 2 days before they actually got the NK cells and up to 3 months afterwards. And so the major issue is ovarian cancer patients do not want to be in the hospital. They're not like the heme patients who are used to being in the hospital for, the bone marrow transplant, long periods of time, and we just could not. Once you told the patient that they had to be in the hospital, up to 3 weeks, because we would have them stay in for the IP delivery, they wanted nothing to do with it. And I underestimated that for sure. But so we did have 2 patients go on the trial. And so what we found was encouraging in these 2 patients. With intraperitoneal delivery of the NK cells, we saw at day 7, so this is when we look for donor-related or donor NK cells in the blood, they did not traffic to the blood, so they stayed within the peritoneal cavity. We looked at the ascites sample on day 7. She had about 36% in donor NK cells. By day 14, that had dropped to 4%, but we knew they were staying within the peritoneal cavity for up to 14 days. Patient number 2, same thing, nothing in the blood at day 7 or day 14, but she actually had expansion, so 24% to 31% within the ascites cavity, which we were excited about. So this lady ended up doing well. So she was off any drugs for 6 months, went back to work, was working full-time, felt really good, and then ultimately ended up recurring and dying from her disease. So based on those 2 patients, we said, we're done. We're stopping this trial because we can't get, we couldn't get anybody on this study. So we had to go back to the drawing board and say, okay, what's next? So we closed the IPNK cell trial, went back to the drawing board and said, what is going to make this, how are we going to change this? And this is kind of the new iteration of this trial. This has not opened yet. We are now going to use an adaptive NK cell infusion called Fate NK100. Have you guys heard of these adaptive NK cells? Anybody? Okay. So went back to the drawing board to all my smart friends who are heme people. And I'm just going to talk to you a little bit about NK cell maturation and the importance of this. So if you look at the maturation cycle of NK cells from the bone marrow to primary lymphoid organs to peripheral blood tissue, this is how NK cells mature. So they go from a pro-NK, pre-NK, and what they do is they basically end up acquiring a CD57 marker. And so they go from CD56 bright to CD56 dim as they mature. And so CD57 is really a late-stage marker for human NK cell maturation. And the acquisition of this marker really represents a shift towards being more cytotoxic, more able to kill. They have greater responsiveness to signaling via CD16, so they can do more ADCC-dependent killing and acquire more natural cytotoxicity receptors. They also produce more cytokines, and so they're better able with these cytokines to kill and response in target cell engagement. The problem with CD57 acquisition, though, is they tend to be less proliferative. They don't respond as well to IL-2 and IL-15. And so the issue is when we do the NK cell product for the allogeneic therapy that we're doing now, we're stimming these with IL-2. And they tend to be not these more mature ones because they tend to mature at a lower stage. And so we believe now that we're not getting as good of a kill because we're triggering them with IL-2. So we also know that CD57 positive NK cells in the peripheral blood increase with age, which is a good thing for those of us who are aging, and is really thought to be driven by cumulative viral infections. And this is where this whole CMV comes into. So the adaptive NK cell population is really kind of a new thought. In 2004, there were data published looking at this unique population of NK cells that express an activating receptor called NKG2C. And they were found only in patients who were CMV seropositive, but not in those patients who are seronegative. So the majority of the population by adulthood, about 60 to 70% of people will be CMV positive. So this NKG2C CD57 NK cells, so this is a mature NK cell population, they really were found to expand after immunosuppressed patients reactivate their CMV infection. And this was found after transplant. So it's this new population that they say we think is more of an adaptive NK cell population. So why is that important? What they found is this adaptive NK cell population, so this subset of NK cells, is really kind of parallel to what we're seeing in the T cell arms of adaptive immunity. So they're long-lived, they stick around a lot longer, they're potent, they produce a lot of cytokines, so significantly increased tumor necrosis factor alpha and interferon gamma production, and they have enhanced target cell killing. So we think it's a better NK cell product, possibly, than what we had before. So there is data to support the use of adaptive NK cells. And this was really out of Jeff Miller's. These were some retrospective studies looking at some of the data that was here from the University of Minnesota. And they looked at the association between CMV reactivation, so cytomegalovirus reactivation, and protection from relapse in patients who are undergoing a hematopoietic stem cell transplant. And they wanted to determine whether these adaptive NK cells played any role in this. And so what they looked at is they looked back at these patients who had reactivated CMV, and they found that these patients had higher absolute numbers of these NKG2C CD57 adaptive NK cells, which really correlated with lower disease relapse and greater disease-free survival. So I think that's kind of stemmed from the fact that maybe the CMV really was important. Frank Saihaki, I can never get his last name right, who was very nice and gave me this slide, really was one who published in Leukemia last year the findings here looking at how adaptive NK cell expansion really is directly associated with lower relapse rates. And what they found is that patients who had lower levels of absolute counts of the CD56 DIM, CD57, this NKG2C positive cell line, the adaptive NK cells, had a 2-year relapse of about 46%, whereas those who had higher numbers had a significantly lower, so 16% disease relapse. So it's from this data that everyone started to say, okay, these might be really important cells in which to move forward in using in clinical trials. So this is where Jeff Miller's team now has combined efforts with a company called Fate, and this is this new product called Fate NK100. This is a novel method for basically ex vivo expansion and enrichment of these adaptive NK cells. So instead of using just allogeneic NK cell therapy that we were using before, our plan is currently to go forward and use these adaptive NK cells. So what we plan to do now is to get the NK cell product from a CMV positive donor. So it'll be a donor related like we were doing before, but we want to make sure that these patients or the donors are CMV positive. And so an apheresis will be done. They're extracted for T and B cells just like we do now. So CD19, CD3 depletion as we currently do. Once this is performed, they are then expanded for 7 days with IL-15, which is a new cytokine that we've been using instead of the IL-2. And I'm going to show you a little bit of our data with a drug called 803, which is a IL-15 superagonist. And then they combine it with a small molecule agent called GSK3 beta inhibitor. So this is a glycogen synthase kinase 3 beta inhibitor. So again, I am not the expert in this, but basically what this does is it helps to expand these adaptive NK cells. And so we get an NKG2C CD57 population of adaptive NK cells with this new product. What we'll be doing is this will be a GMP-compliant product that will be used in our new trial. So basically, this is our new clinical trial that we are putting forth. It's going through the IRB right now. As you can see here, we've taken out the high-dose Cytoxan and the fludarabine. We think, we're surmising, that the intraperitoneal cavity is more of a restricted environment, that hopefully we don't have to do the high-dose chemotherapy to basically create a space, because this is a kind of an immune space in itself that we'll deliver directly into. So we've taken out the high-dose chemotherapy. This is going to be done with a 1-day admission. Patients will be coming in. The donor apheresis will occur here with the CMV positive Fate product, like I talked about. Patients will come in and the NK cells will be delivered intraperitoneally. They'll be able to go home and come back as an outpatient for the IL-2 dosing. And the IL-2 dosing, our hope is, will allow those NK cells to expand within the peritoneal cavity. We're going to continue with the oral IDO dosing, starting at minus day 2, and we're at this dose level now at 100 milligrams twice daily. So we're hoping with this new regimen that we'll be able to do this as an outpatient. This will be in recurrent ovarian cancer patients, and they won't have to be hospitalized as long. our goal is to basically, this again will still be a phase 1 trial looking at the maximum tolerated dose of this IDO inhibitor. That's how this was originally written. And we'll look for toxicity. So far to date, we haven't had any toxicity associated with the IDO. I think this will be a much less toxic regimen because we've gotten rid of the high-dose Cytoxan and fludarabine regimen. We're really going to want to look at, and we're going to get peritoneal washings on day 7 and 14, as well as blood levels to, again, look at expansion within the peritoneal cavity. So yesterday I was saying, now what do we do? So I said, well, I don't have to do anything because all we have to do is take these pills, these NK cells, and these are really going to support NK cell production for the sale price of $26.44. So I was like, our job is done here. So I'm going to go on now and talk to you a little bit about IL-15. So if you remember, in this new FATE product, we're using IL-15 to stimulate these adaptive NK cells. So interleukin-15 is basically a cytokine. It's a growth factor that we know is capable of expanding, activating T cells as well as NK cells. If you look up IL-15 in the immunotherapy meetings, they basically rank this as the number 1 agent with high potential for immunotherapy, most promising candidate to potentially cure cancer. Well, it hasn't cured cancer yet, but I do think there is some potential here, and I'm going to show you what this is. So Dr. Miller, Jeff Miller, has combined efforts, or we've combined efforts with Altor Bioscience, and it's a company that has the drug that's called ALT-803. And so basically, this is a IL-15 superagonist, if you will. So if you look here, this is the IgG1 Fc portion domain right there in the blue, with the IL-15 that's in here, that's the light green, and then this is the IL-15 receptor alpha that's in the dark green. This is a sushi domain. Basically, what this IL-15 molecule does, it has a mutation that allows it to further enhance IL-15 signaling. And so really, there's a 25-fold increase in the biological activity with this IL-15 superagonist. So in our laboratory currently, what we've done is we've looked at the use of ALT-803 to increase functionality against ovarian cancer cell lines. And remember before when I showed that original diagram of all the ovarian cancer cell lines. So now what we've done is take multiple different ovarian cancer cell lines and looked at in comparison to, so the K562 is kind of the prototypic NK cell line that is killed by NK cells. And we've compared it. So you can see there's a significant increase in CD107A, which is a marker for degranulation, with the addition of ALT-803 to all of these NK cell lines. So they've all gone up with that. So we were encouraged with our cell line data. We also looked at the production of interferon gamma and TNF-alpha. I didn't show all the data for the TNF-alpha, but again, similar story. We found significant increases in inflammatory cytokines with the addition of the ALT-803 to all these different ovarian cancer cell lines with the NK. So what we really want to do is look at, within the peritoneal cavity, there's a lot of ascites. We don't really know what the effect of ascites does to NK cells within the peritoneal cavity. So we wanted to look at the effect of the soluble ovarian tumor microenvironment on basically on healthy peripheral blood NK cells. So what these diagrams show is that ALT-803 really can rescue functionality on normal donor NK cells that are incubated with ovarian cancer patient ascites. So we took 10 samples of ascites from advanced stage ovarian cancer patients, and we treated them with peripheral blood mononuclear cells, NK cells, from normal donors with the ascites, and we put them against the K562 target, so the prototypic target. And as you can see here, I don't know if it's easier to see with this maybe. If you look at the NK562 plus the ALT here, so this is just the normal cell lines without the ascites. So here's basically NK cells against the K562. You get improved degranulation with the addition of ALT. If you look at here, so this is when we add ascites to those peripheral blood mononuclear cells, you see significant decrease in that. So the ascites really decreases degranulation. But when we add the ALT-803, when we add the ALT-803, you really see that increase in degranulation again. So it kind of rescues it up to the point of where, your normal peripheral blood mononuclear cells can be. And so we did this again for interferon gamma and TNF alpha here. And you can see baseline ascites really drives those levels down. But with the addition of ALT-803, it kind of rescues both that cytokine function. So we were excited to see that because we know that the ascites really decreases degranulation and cytokine production. So then what we next did is we tested whether or not NK cells that are exposed to ovarian cancer tumor microenvironment would react similarly with ALT-803. So we used, again, the K562 targets to induce NK cell function in these assays. And so what we saw, so these were patients, these are actually NK cells derived from the ascites. So we had the multiple ascites samples, we took the pelleted cells, and we derived the NK cells from them. And then what we saw is, if you look at, this is normal peripheral blood NK cells. These are the NK cells derived from the ascites. If you look at here, just baseline with the addition of all, the CD107A goes up, so degranulation goes up. If you look at here, it's the same thing. So the NK cells that are derived from the ascites, these are lower than just baseline, right? Can you see that? Lower than baseline. With the ALT-803, that again increases. So with ALT-803, and we see that again with both the cytokine production. So with ALT-803, we can approximate healthy donor peripheral blood NK cells that are not stimulated with ALT-803. So we can bring that level up with the addition of ALT-803. What we also found in the midst of doing this, and this kind of goes off on kind of our next plan or what we're looking at, is that with the addition of ALT-803, we can induce interferon gamma production. And with the induction of interferon gamma production, we actually upregulate PD-L1, so programmed cell death ligand 1, on ovarian cancer cells. And that's just what this is showing here. So the red shows negative PD-1, and then the orange are where we upregulate, and you can see production of PD-L1. And I'll tell you why that's important. So I'm sure all of you, I mean, this is the latest and greatest, is the use of this checkpoint inhibitors. The drug pembrolizumab, which basically cured President Carter with his melanoma. So, everyone's kind of rushing to use these checkpoint inhibitors now. So basically, upregulation of PD-1 and PD-L1 is a mechanism to evade the host immune system. And so this is just what this cartoon is basically showing here. So if this is their NK cell, it has a PD-1 on its membrane surface. Ovarian cancer cells have PD-L1. And once, these connect here, this kind of recognizes this as self when PD-1 binds to its ligand and the immune cell response is inhibited. And so ovarian cancer, we know, can upregulate surface expression of PD-L1 to basically suppress and evade immune response against it. And so that's one of the mechanisms that we now know ovarian cancer can use to evade the immune system. And so why this is important is there's this drug, Keytruda, or a drug called pembrolizumab, that's now available and is being tested in early phase trials in ovarian cancer. So Keytruda basically blocks the inhibitory signal to PD-1 on the immune cells. So it's an antibody that inhibits this and allows, so when this is blocked, it can't recognize the PD-L1 signal on the ovarian cancer, and then allows for increased immune cell cytotoxicity against ovarian cancer. So when we saw the upregulation of interferon gamma, and we also then found that PD-L1 was upregulated on ovarian cancer, we thought, well, maybe in combination with ALT-803 with this drug Keytruda, we could do something else. So our hypothesis here as a result of these studies showed that basically combining NK cell expansion using ALT-803 with blocking the signaling pathway, the PD-1, PD-L1 pathway using Keytruda will basically induce NK cell-mediated killing and may be a novel therapeutic way to fight this disease. Our current model, so we have a MA148 xenogenic mouse model of ovarian cancer, and that we're currently testing. And again, this is preliminary data that I'm just showing you here now. And so What we do is we establish tumor. We deliver the MA148 cells intraperitoneally. We do irradiate these mice, and then we deliver NK cells. So this is, again, the same product that we use clinically, a CD3, CD19 depleted product given IP. We've then been delivering ALT-803 intraperitoneally with an PD-1 blocking antibody, so that Keytruda that I was speaking of. We're measuring, we're looking at bioluminescent imaging on day 7 and day 14. We repeat dosing 4 times during this time period. So what we found is that the combination of both drugs, the ALT-803 and the Keytruda, given IP, really does appear to enhance tumor control. So if you look at here, in terms of this is the combined treatment, by day 7, there's a significant decrease in the BLI that we looked at in the luminescent imaging. And again, here at day 14, even more suppression. So we were encouraged by this data out to day 14. More recently, so this is our recent data looking at survival. So we did that same experiment, and then instead of sacrificing mice, we allowed them to continue to grow out, and we looked at survival curves. So if you look at here, the tumor-only group is the blue, the NK cell-only group is the red, NK plus ALT is purple, and then NK plus ALT and pembrolizumab combined together. So now I do have to say the weird thing about this is that usually when you give NK cells intraperitoneally, they'll die off much more quickly. I don't know if there's some sort of cytokine enhancement in that group that's causing these to stay alive longer, because we shouldn't be seeing that. So whether there's something in the ascites that these mice are making that's causing them to stay alive longer. But long story short of that, there's, if you look at tumor alone versus this arm, there's a significant improvement. So in terms of survival, and again, this is preliminary data. We're repeating this, but I thought I would just show you this in the beginning. So what we really have come away with is that we think that ALT-803 can help to overcome NK cell function deficiencies that are found in the ovarian cancer tumor microenvironment. With this, we're really excited. This is a new clinical trial. Now, again, I showed you the picture of all the ovarian cancer tumor. I mean, clearly, we're not going to cure women with that much disease with NK cell therapy. I mean, it just isn't going to happen. I think what we need to do is to bring this therapy earlier front line. So when these patients have small volume disease or microscopic disease, there's something there because it's coming back. So we're really trying to move this forward in terms of therapy earlier in the course of disease. So this is the trial that we plan to hopefully open this spring. This is a randomized study of basically intraperitoneally delivered ALT-803, so the drug that we just showed you, followed by subcutaneous maintenance of ALT-803 in advanced patients who have received IP chemotherapy. So the majority of the patients, when they come in, they're going to be debulked. We put an intraperitoneal catheter in. They receive 6 cycles of IV IP chemotherapy, usually cisplatin and Taxol. At that point, we usually pull the intraperitoneal catheters. Our plan now is hopefully to do a single-center randomized phase 2 study looking at this use of ALT-803, giving IP kind of as a maintenance therapy in these patients. Now, there's been no prospective randomized study that's really improved survival in ovarian cancer patients with maintenance therapy. So we don't tend to give it. Patients always want something else. They say, what do I do between now and when this disease recurs? And we really have nothing for them. And so I think this is why this will be a trial patients will want to go on, and hopefully we'll be able to show that we can prolong progression-free survival. So patients, let me just show you the design. So basically, this is the schema. Patients will either receive intraperitoneal ALT-803 or subcutaneous ALT-803. So the first one, arm 1 here, this is no IP. So these patients are just going to receive sub-Q ALT-803. And this is really based on some of the data that Jeff Miller, he's been using this drug. They looked at it IV originally. Patients had a lot of cytokine release, were really sick. They've now changed to subcutaneous dosing, and patients seem to tolerate much better localized reaction only. So with the subcutaneous dosing, what we're going to do and what we have nice access to is we have the catheter still in. So we're going to be able to draw off peritoneal washings so we can determine at baseline, and as time goes on, what the immune milieu looks like within the intraperitoneal cavity. So they'll get the sub-Q doses 4 times. We'll draw intraperitoneal fluid right before each dose. They get a 4-week rest period, at which time we'll take out the IP catheter. The other arm is going to receive IP Alt-803, and we're going to do the exact same thing. We're going to test the intraperitoneal washings. And really what we want to do is determine what is the safest route, and can we get increased NK cells and immune cells within the peritoneal cavity? Is it more with IP delivery versus sub-Q? The rest of it, and then everybody's going to receive sub-Q maintenance of Alt-803 for 3 additional cycles until disease progression. And so the objective is really, we need to select a winner. Is there a winner? Can we determine, is one method clearly inferior to the other? We're really going to look at, attraction of lymphocytes into the peritoneal cavity, ease of methodology. Is it safe to keep these catheters in, which we think it will be, and so we'll look at that. Our secondary objectives are look at progression-free survival and overall survival. And then obviously we'll look at peripheral blood and peritoneal washing lymphocyte number and phenotype and function. So to conclude, basically the goal of all this work has been to look at the use of Alt-803 preclinically with the addition of the PD-1 inhibitor. Our hope is that ultimately we'll be able to have enough preclinical data so that we can add the pembrolizumab to the trial that I just talked about with you. We think, these hopefully will optimize immune activation, and if we can bring it earlier in the stage of disease, that we're going to be able to make a difference. Because clearly, like I said, with that volume of disease these patients have at the time of recurrence, we're not going to truly change the outcome. We now believe that PD-1 and PD-L1 pathway really is involved in inhibition of NK cell function. We now have a drug in which that can inhibit the PD-L1 pathway, and we're hoping that we can have enough data to add that to our current trial and really take advantage of the cytokine-induced PD-1 upregulation we see with NK cells. And if we can introduce this Keytruda, that will change our outcomes in these patients. So I have to thank the members of, especially Martine Felices, who's really done a huge amount of this work here, as well as Jeff Miller, Sarah Cooley, Amy Skubitz, who gave us all of our ascites samples that she's coveted for many, many years, Laura Benzik and Caitlin Ryan, and the rest of the group here. So I thank you for your attention, and I'm happy to answer any questions that you may have.
Thank you. Do you know what it is about the CD57 NK cells that allows them to persist?
So when they get to that more mature part, they think that with the small molecule inhibitor that that's producing. I don't know exactly what the mechanism is, but if you look at the preclinical data without that small molecule inhibitor, it doesn't persist. It's like a downstream PI3 kinase inhibitor, and for whatever, if you look at the two, there's something with the monocytes too that's ongoing. Because if you take out those monocytes, those CD57s don't persist.
Thank you.
Is there an association between CMV reactivation or just being CMV positive with the outcome?
So it can occur in any, people can get pretty sick with these heme, and again, I'm not a heme physician who does these transplants, but there's that fine line between reactivation versus getting very clinically ill between it. So anybody who's had CMV, previously, they see these CD57 positive NKG2C population with them. So it doesn't necessarily have to be reactivation. They're just CMV at any time. And the majority of the population, about 60% of the population by adulthood, will be CMV positive. About 37% of the transplants that have been done here have now been done with CMV positive donors. And they've seen no side effects, no reactions with that. But it's that fine line between when they are so immunosuppressive, getting too sick from the CMV reactivation. But these are just CMV positive donors, not necessarily reactivated.
So the sustained common gamma chain cytokine signaling like IL-15, IL-7 has been shown in other cell types to actually sometimes program immunosuppressive programs like IL-10 production. And NK cells actually can produce IL-10 under certain situations. Are you interested at all in looking at some of other mechanisms of NK cells, not just the pro-inflammatory?
Yeah, I mean, I think there's that whole gamut of, I didn't show this data too, but in terms of looking at the T regulatory cells and what's happening with after the high dose cytoxin and fludarabine, we see significant T reg upregulation. I mean, so that's that whole interaction of trying to, we added some steroids to try to reduce that T reg upregulation and try to mechanism with that clinically, but patients got so sick. It's hard to do, but there's a whole gamut of things that we can look at with that.
Okay. Do they metastasize? And if so, where do they metastasize to? And is the mechanism understood? Do they actually invade mesothelial layer or
the
ovarian cancer
the
cells?
They do metastasize.
Is that common, or is that
just within the peritoneal cavity, though, for the most part? I mean, it's rare to see metastasis outside of the peritoneal cavity.
not a distant?
Not a distant type of mats. I mean, literally. I mean, like I said, I think I can count on two hands the number of patients that I've had distant mats, like to the brain or to skin mats or something. I mean, it's rare.
And are they highly vascularized?
Yes.
They are. And that correlates with...
And that goes along with the whole VEGF. So there's, data when they originally looked at this about the T cell infiltrating tumors had significant, those patients who had worse outcomes had high levels of VEGF within their tumors too.
Thank you.
Sorry, I might have missed it, but did you figure out what might be in the ascites that has that suppressive effect?
It's a really good question. And so we've looked at ascites and the actual, in our laboratory, about the NK cells and their function. And there's fewer mature NK cells within the peritoneal cavity. I didn't show all that data, but we knew that there's fewer NK cells within the peritoneal cavity. They are less mature and produce fewer cytokines. And there's a whole gamut of other things that, obviously Tregs and everything within the peritoneal cavity that we really have not completely defined.
So, Melissa, in the checkpoint inhibitor world, there's a belief that mutation load plays some role in predicting benefit from that. And I know not all ovarian cancers have high mutational loads.
Right.
So do you think, the BRCA-like ovarian cancers are going to be more or less sensitive? I guess the question is, do you care? And I'm asking in the context, obviously, I think about breast cancer, but in breast cancer, if you did a trial like this in all comers, it would not likely work because many of them are just not that immunogenic.
Right.
So do you care about that in your design, or?
I think it's a really good question. I think that we were excited with the effect that we saw with the increased interferon gamma production. We saw the upregulation of the PD-L1 on the ovarian cancer cell line, and that's what kind of triggered this whole investigation into using the pembrolizumab. I think ultimately we will care as to for the exact reasons that you say. Again, we're just doing this initial study, and then I think we're going to have to parse out who exactly these people are. And if you look at the ovarian cancer population, we're finding more and more with these HRD-like, tumors. And so will we be able to treat a larger population than we originally thought? It's possible. But we may, I think we're finding out everybody's getting tested now. All these tumors are getting tested. So I think we're going to be able to define that population better coming forward.
There are no data connecting antigenic load to NK reactivity, are there, Doug? I mean, most of those data look at T cells, and so I mean, we will probably find out something new about NK cells that we didn't know in an hour and tomorrow. But I mean, I think that the because you are starting with NK cells, the antigenic load might be irrelevant, and what you conceivably could do is these guys are all getting surgery.
Yeah, they will have had surgery and then upfront therapy.
So you're starting with minimal residual disease, and so the question is whether there's anything really obvious for the immune system to see that's not behind the barrier, right? And so it might be worthwhile to think about some really nasty insult that unmasks tumor and breaks that immunosuppressive barrier before you start immunotherapy, maybe giving it closer to surgery or something like that. I'm not sure if you guys have thought about that.
It's a good thought. We haven't. You mean before actually going in for the OR? Yeah.
Or at the time, so that the cells have a chance to see tumor gamish, as opposed to trying to find renegade cells that may still be hidden.
But I would think you'd have to have a balance between the massiveness of the disease that's there prior to surgery.
Yeah, it's almost like you need, more small volume disease. Yeah. Because theoretically, it's microscopic afterwards, or.
Is there any reason why you can't reinfuse? Is there any reason why you can't give more cells?
No, I mean, and again, that's the thought about redosing.
Are there no predictors for that disease reoccurrence?
So yeah,
to characterize maybe the tumor microenvironment at like the first surgery to
predict who's going to recur and who's not.
Yeah.
Unfortunately, isn't that sad? We really have no good predictors. I mean, the only thing that if you can't optimally cytoreduce a person, then that's kind of like they're in their own group of people on their own. But for the patients we optimally cytoreduce, we can't predict who's going to recur within 2 years or who's going to predict 3 years later. I mean, we don't have that capability. We've tried to do with proteomic profiling of the tumors, and is one more immunogenic than the other? There's some data to suggest that these immunogenic tumors do better, but again, there's really no baseline predictive test.
If there are no more questions, let's thank Dr.
Thank you.